I agree. Welcome, Emmanuel. Welcome. Good to see you. Welcome. We are just so we are 6:30. Thank you. Do you want to introduce us and then we'll swing
Certainly.
on?
Good evening, everyone, and welcome to our podcast. We are pharmacists and we work within the community health services. We've been running our podcast since March, I believe, and it's been a very, very informative session, very interactive session. I want to say a big welcome because we've had a break over the summer, and it's been an opportunity for people to sort of refocus on the priorities because I think over the summertime, Timmy, you would agree with me that the pressure is quite high simply based on the fact that individuals, organizations have annual leave and a lot of people enjoying holiday, and that was put into consideration, and hence the reason why we had a break. So I just want to welcome to everyone for joining us today. And today we are going to be focusing on patient group directions in community health services and having discussions about that. There are certain, key aims that we want to sort of achieve today. I'll probably introduce myself for those that haven't, heard me before. My name is Jenkyo Ololoba, and I'm the head of medicines management within the Medway Community Health Care. I'm pleased to be obviously joining Tammy here, having this, conversations and experiences within the community health services and what medicines management means to us and what we're doing within the community health services sector. So I'll probably hand over to Tammy. Um, Tammy, give us a brief introduction for those that may or may not know you and what you do.
Thank you. My name is Temi Topi. I'm the head of medicine management for First Community Health and Care. We are a community health service down in Surrey, within the Surrey Heartlands ICB. And we look after patients in their own home, in the minor injury unit, in an inpatient rehabilitation ward, and we obviously look after all things immunization and urgent community response. We've got quite a number of services, obviously, under us. And so my role is all things medicine for my organization as a whole, and making sure that in terms of leadership, in terms of guidance, in terms of training is all um, in where within obviously fulfilling our regulators standards. So that is me in a nutshell. As Jenkins said, we have set up this LinkedIn audio event, obviously to educate um, um, the community around community health service, because we know it's an area that not a lot of people know about, that they exist or what they do, especially when it comes to medicine management, and to provide support in any way we can or answer question in any way we can from our experience of actually working in the community health service. I believe Jenko has been in the community health service for probably a good part of 6 years. And I have been, sorry,
I said yes,
and
you're correct.
I think I've been in the community health service now from my time in Guys and St. Thomas's for about 7, 8 years. So yeah, so it's been a while trying to do that work. It's been interesting and wonderful to be able to be part of that service. So we're gonna be talking about all things PGD within community health service, and I'm gonna do the nice bit, and I'm gonna get Jenkins to do the interesting bits because she loves governance. So I thought is I
I,
area
li-
of
I like
strength.
I like the way you've coined it, the nice bits and the interesting bits. Do you mean the tricky bits? I don't think so. But go on with the nice bit, Timmy. It's interesting that you say that.
Oh wow. So PGD, for people that don't know, which is patient group direction, and just to put a bit of background to it, within United Kingdom, there are three ways in which you can supply or administer medicine, as in obviously under the Medicine Act. And the idea is that you have to have a prescriber to be able to give you that medicine, or you are able to source it because you obviously you had a consultation with your pharmacist. But when it comes to prescription only medicine, there are three ways. The first one is through an FP10, which you get from the GP surgery. The second is through the PGD, which is the patient group direction, which we'll be talking about today. And the third one is through the PSD, which is patient specific direction. And so the reality is there are regulations, obviously, that govern this. And there are a whole lot of process that is involved in actually getting a PGD rectified. And so it's important that any organization that wants to access a PGD needs to really decide if they want to actually um, do they really need a PGD? And SPS, which is the Specialist Pharmacy Service, has actually done a very fantastic document that says to PGD or not to PGD. And I think that document is really good because it lays a foundation to actually decide from the beginning, before you even start to draft your PGD or anything, to say, do I actually need a PGD? The reason why PGD is quite important in the community health service, for people that are not aware of community health service, most community health service, they are nurse led, they are not pharmacist led, and not all the pharmacists can prescribe, and so a PGD is needed to be able to administer medicine or to be able to supply medicine. And so it's important that, so this PGD, they're not for doctors, as you can imagine. They're actually for nurses or non people that are not prescriber within the service. So you will see this sort of PGD used in the life of minor injury unit, in working centers, in an immunization service, in a MSK service. So you get them, you get that used in those areas, and it's quite important because you're dealing with um, different group of staff, e.g., physiotherapists or nurses, and podiatry as well. People that do feet and things, they use it as well. So very important that before we even start out, we need to decide, actually, do we need a PGD? And like I said, a good document to start with to make that decision is the SPS document. And then if we actually decide that we need a PGD, or some form of guidance for people to be able to administer medicine, then the next stage will be, okay, do we need a PGD or do we need a protocol? Because even one of the things the SPS also put in place is that, yes, you want people to have a clear guidance of how to administer medicine, or you really only need a PGD for prescription only medicine. And so one of the things SPS has put in place is that they've actually produced some protocols you can use and adapt to their services, if they come to a point. So I'll give you an example. Within my service, we don't necessarily steal children. However, people walking from the street because their child are not well, and we can't just turn them away without doing nothing. And so they will need to give, for example, paracetamol, ibuprofen, but those are over-the-counter medicine. But we might want to give them something while they're in the service, and then we can now signpost them to say, okay, you can go and get some from your chemist. And so the way to do it is to have what we call a protocol, which was is there are templates within the SPS, which is the specialist pharmacist service, and they have those templates, and we can actually use those templates to actually produce those a protocol, and that will be bespoke for our service. And so there, there are times in which people have got PGD within their service, but they don't really need a PGD. All they need is a protocol. And it's important to actually know, because having a protocol and a PGD is slightly different, because the protocol gives you a bit more flexibility, whereas the PGD, it has to be authorized. And Jenkyo is going to be talking a lot about that later. So once we've decided that, okay, we don't need we need a PGD, or we don't need a PGD. So we've gone through the process of whether it's PGD or no PGD. We've had a look at the template, and we're thinking, okay, the template is not the protocol is not the way to go, because we're not doing P medicine or we're not doing GSM medicine. The next stage to that is actually to think, okay, is there a national template I can use? Because the thing is that, I don't know about other people, there is no point reinventing the wheel. If there is a national template that you can use, really and truly, you really want to do all that work again. And this national template is being ratified by a panel. It's gone through different approval process. Do you really want to do all that work again? So again, SPS has actually done a lot of work, and I can say I'm privileged to be involved in that piece of work that was done by the Specialist Pharmacy Service, and being part of the panel that actually ratified some of these national templates. And so there are templates that are on the SPS website that people can actually access and use them. And you just need to obviously look at what time they expire, and then just make sure that SPS has got another one in, when to go on their website again to get the next one, and that's been obviously reviewed. So you can actually use the national template if indeed PGD is the only way to obviously administer or to supply medicine within that service. Then SPS might have some templates already that you can just adopt into your organization, rather than having to go through that whole process of actually drafting your own, because it's a lot of work to actually draft a PGD, a brand new PGD. And depending on where you are in the country, different process might apply, which I believe, again, Jenkyo will be talking about that. So the question is, actually, is there a national template that I can use for this? So have a look again. If you are in that place, and if you need support, you can drop Jenkyo and I an email, and we can send you, we can signpost you. But SPS website, which is again Specialist Pharmacies Service website, is full of information, different template that you can use, and that will really help with that. So after we've done, okay, we've decided that, okay, we need a PGD, the national template, there isn't any obviously that we can use. So we obviously need to think, so who should write this PGD? So very important, we need to decide who should write PGD. And I think in this place is important to let, because there is an assumption that PGD is meant to be, the author is meant to be a pharmacist. That is not true. I can tell you it is not true. So the pharmacist does not need to be the author of a PGD. And I've clarified that from the Society of Therapists. I've clarified that from the NMC, and I am very, the pharmacist does not have to be the author of a PGD. especially if it's a service that you know nothing about. So I'll give you an example. I have a service within my organization, the MSK musculoskeletal service. I don't know anything about physio. I don't know anything about injecting into the joints and things like that. So writing a PGD for that service as a pharmacist, I don't think is the right thing, because I don't know much about that service. I can support them, but they run the service and they know what they want to do. They know the anatomy around the injection into the site and everything. However, our specialty comes in when it comes to the medication, and now the medication to be supplied, how, the dose and everything. Yes, that is our area of specialty. But when it comes to actually writing the draft of the PGD, that should be the service manager or the clinical lead should be taking responsibility for writing that PGD, because they know the service, they know the model of the service, and they know what exactly they're trying to deliver. They know the group of patients they want to serve. And so they are in the best position to actually write the PGD. So it's very important that we nail that down here, to say that it is not the role of the pharmacist to write PGD. The pharmacist is there to support the writing of the PGD. However, we also need to be mindful that yes, we are involved with the writing, but as requested by NICE, and there's a clear NICE guidance about who should write PGD. Who should be involved in the PGD. So the NICE guidance and even some guidance that I read from MHRA did not actually say this is the person that should write the PGD. However, they are very clear on who should be involved in writing PGD. And definitely you need a pharmacist, you need a doctor, you need a nurse, and you need the clinical service nurse, or should I say not necessarily nurse, but somebody who has the clinical governance lead for that organization. So sometimes, if not most, the clinical lead for the organization as a whole is usually a nurse. But whoever that is obviously needs to be the person that will take responsibility for that PGD. And then you have depending on what the PGD is about, you find that so for instance, we try to involve our orthopedic surgeon in our MSK PGD, just to get their view. The antibiotic PGD, we involve the microbiologist, because we need to know in terms of microbiology sensitivity in that population. So it's very important that you know who is going to write this PGD and who needs to be involved in writing this PGD. Very important. Again, before we start, even at the time of planning that process, we also need to think about where are we going to get this medicine from, especially if you intend to give the patient something after you've assessed them. So for instance, UTI, patient come with urinary tract infection, we assess very important because they need to be labeled already, and not every organization actually provide that service. So they call it TTO pack, or they call it over-labeled medicine. Not every organization deliver that service. And if you work in certain patch in certain places in the country, actually there are a handful of people, or should I say handful of service or organization that actually deliver that service. And so your planning has to be watertight, because what you don't want to do is have a PGD ready, but you can't supply medicine. Then you can't move ahead, because the medicine, you need the medicine to be able to actually supply to be able to work with that PGD. So there's no point saying, no, come out, I'll assess you for urinary tract infection, and then you assess the patient and then you send them back to their GP to get antibiotics. That kind of just defeats the whole purpose of the assessment, because the idea is that they should walk away with their treatment in their hand. And so it's important that you are able to talk to, especially if you don't have a PGD in your organization, it's important that you need to talk to different organizations who are already doing this, to be able to say, how do I source the medicine? What do I need to put in place? And to actually actively, connect with the organization, let them know your timeline, let them know how quickly you need, what is the time frame for, obviously, start to deliver this service, and making sure that they can actually deliver what you need within that time frame. Sometimes, in my experience, it's been about 3 months to actually set up an over-label medication, and for it, from getting the specification right, getting, the authorization from myself, getting the authorization from the organization, making sure that the services are happy, and then obviously now deciding, okay, how many are we going to obviously order for the first time to see, and obviously the uptake of the service. So very important that the time frame, we are quite, if we're not sure, 3 months is a good way to start, to say, okay, I want to deliver the service in 3 months. I'm giving the people that's going to supply the medicine opportunity to put together the specification and everything. And obviously, you as a person, or the pharmacist will be in charge of this bit of it, because obviously that's our area of specialty. And so you need to make sure that you're actually following it up and saying, are we going to get the medicine? When are we going to get the medicine? And just making sure you're following up with the service, so that you don't come to a place that the service is ready to start tomorrow and there's no medicine on ground to actually treat the patients that are there. And lastly, before I hand over to Jenku, I'm just going to talk briefly about policy, competency, and training. So it is important as an organization to have some form of guidance or policy around PGD. And depending on which organization you are, whether, I think when we first spoke about community health service, we mentioned the fact that there are different types of community health service. There are community health service that are standalone. There are community health service that are linked to an hospital. There are community health service that are linked to like a federation. And so the authorization process is different depending on the organization structure. And so whoever will approve the PGD before it can be used is also different. So for example, and so there are times that, so I'll give you an example. If an organization, i.e. the community health service, is linked to an hospital, the authorization is almost seamless, and they probably won't need to do that much presentation because it's almost seen as the same organization. Whereas if it's a standalone community health service plugging into an ICB, then it's different, because you will have to adopt the ICB's process of PGD rectification. You cannot rectify the PGD, so you will have to adopt that process. So it's important that before you write your policy or your guidance as a community health service, you know exactly what the ICB, what your organization structure is, and what is required in terms of approval, because there's no point writing a policy that is just a paper. You can't do anything with it because you have no control, because the commissioner have a control over that PGD. So very important, because that policy should include competency and training for anyone who's going to work under the PGD. And this is quite important because there is a clear guidance from NICE and there's a whole document from NICE about PGD. And there are three levels of training. There is the training for two levels of training. There is a training for the people who are going to write the PGD. So authors of the PGD or people that are reviewing PGD. There is a training for the people that are involved in a PGD. And yes, there is a third one, and there is a training for the people who are going to be using the PGD. So let me try and break that down. So for example, the people on ground who are the nurses who are going to be using the PGD, they need to have a training. The people that are going to be signing the PGD off on behalf of the organization needs to have some level of understanding. So they need to have, if they're not sure, they need to know a bit on that. And then the people who are going to be writing the PGD, and this will be the clinical leads or they will be the service manager, they need to have training. And so as an organization, in your policy, that should be clearly stated in terms of what training they need, how the training will be delivered. Is it going to be delivered in-house? Are you going to be sourcing it from ELFH? Or are you going to be sourcing it from another place? Or is there something that is already in place? For example, we know CPPE and for the Royal Pharmacy Society in the UK has got something that you can plug into. We know that Learning for Health has got something to plug into, and then you can actually have your own bespoke training for the people who are actually going to be using the PGD, because you might want to tell them something slightly different, which is specialized to you as an organization. So it's important that obviously the training is in place and is integrated, or should I say included in your policy, because if it's not there, then it's very likely people will not know they need to do training and they just think they can just hit the ground running. And that can be far from the truth, especially during COVID, that actually there was so much training around obviously COVID vaccine and how it needs to be done, and some obviously sign off that needs to happen before nurses can actually start to vaccinate people. So very important to address that. And then the competency, which should be the last thing I'm going to mention before I hand over to Jenkyo, is with the competency, there is no point actually reinventing the wheel, because NICE actually has got a competency document, and the nurses or whoever is going to be working under the PGD just need to assess themselves based on that competency document. And obviously you having a discussion with the nurses on a yearly, NICE actually recommend like a yearly review to make sure that they're still confident and competent to deliver to deliver the service under the PGD. And I think that is important. So there are things that are already, in a nutshell, there are things that are already in place, I believe, that we can use, and we don't necessarily have to start from scratch, especially if we're developing a new PGD. However, we need to be aware of how we can find them and like that. And you can actually find that from the other service, actually, where did they get their medicine from? And now you can actually adopt their process if it's the sort of direction you're wanting to go. So I'm going to hand over to Jenkyo, who's going to be talking all things governance, obviously from different healthcare professional to the content of the PGD authorization process and signatory and renewal process, and a bit about obviously public health PGD. So those are immunization and vaccination PGD, and obviously, and lastly, hopefully touch on audit and expiry dates and how everything governance. So I'll hand over to Jenkin.
Thank you very
Thank
much,
you.
Amy. I think, it's interesting having to get a full background of the patient group directions, which obviously we've coined as a PGD as an acronym, and why we need those. I mean, it's probably important to give examples of where PGDs have been used. I know we're focusing on community health services, but we realize that now within the community pharmacy, able to putting too much pressures on prescribing certain medication. When we look at the governance of PGDs and with everything that Tammy has rightfully said, it's important to realize that the patient group directions is not I usually look at it from a, I'm not a food, well, I am a foodie, but it's important to look at it from a food aspect, and that's how I see it. When you go into a buffet, you've got all sides, everything that you can eat, all you can eat. A PGD is not a whole you can eat, so which means it's a specific criteria for certain indication. So you go in, if I give an example, and that's not particularly reflective of what the PGD content is. So if you're trying to treat a urinary tract infection, you would only look at the criteria of patients, because you are bearing in mind that healthcare professionals that will be supplying or administering this under these PGDs are restricted. They're not prescribers, they're not independent prescribers, they're not doctors. So which means we're giving them a set guidelines on what they should be supplying using those PGDs. So we've got examples of PGDs that you will use in community pharmacy, for example. The flu vaccine is a very, very good example. So you would administer medicine, flu vaccine under the national PGD, which means pharmacies are also being given the opportunity to be able to administer this prescription-only medicines without the need of a doctor prescribing it. So yes, Tammy, in terms of governance, I think it's important to look at the need for the PGD, which you have discussed, whether you need a PGD or not, looking at the medicines requirements, but you also look at it in terms of what you're being commissioned to offer, the service you're commissioned to offer within your organization. So you consider the fact that, is this a need within the service? Do we have enough prescribers? Do we, the whole point of, PGDs is when you do not have enough prescribers and you want to be able to meet the need of the population. And is looking at it that, do we have enough prescribers? And if we do not, then what do we have to put in an interim to ensure that those individuals that are not prescribers, but also, qualified healthcare professionals are able to supply and or administer medicines under these directives. Within an organization, Tammy rightfully talked about the policy. I think various organizations have different policies in terms of, how they're delivering the patient group direction within the organization. But I would always refer to the NICE guidance, because it gives you, what are the key points that we need to have within the policy. So from a governance, having a governance structure on who takes that full oversight of your patient group direction within the organization. And the beauty about community health services is that you as a pharmacist will probably get involved in most of this process, whereas out in the community it's probably done from a probably head office point of view, and then it gets cascaded to local pharmacies. Or if you're working in a larger organization, you probably have certain individuals having worked on those documents, and then gets cascaded to individuals out in downwards, really, for that to be used. So we need to understand that we have a governance oversight of who will be monitoring the use of the patient PGDs within the organization. How is it being used effectively? What assurance can we get that those PGDs are being used in an effective manner? And then we looked at training. So having looked at the training, which Tammy has already touched upon, the various trainings for the different levels of individuals. So you've got training for those that develop, training for those that review, and training for those that administer the PGDs. And those levels, it's important that those individuals go through those training, go through some competency level to identify if there are any gaps in their learning. And it's also very good that there are constant review of the medicines that are under those PGDs to see that actually, is it meeting the needs of the service? I've had a service within my organization where I've looked at all the PGDs, and we've had to stop some PGDs because we've thought actually you no longer need it. We've had an increase in prescribers within your service, and some of them are non and void because the cohort of patients that you are getting does not meet the PGDs that you've got. And some of them you might have to sort of look at the various criterias, and those criterias would determine the sort of PGDs that you would need to develop. So that's, in a way, it's trying to establish your governance around PGDs, making sure that the PGDs are right for your organization, right for the population, and right for those individuals delivering the service. I then consider, going back to the NICE guidance. The NICE guidance has a very fantastic template, but it's also important that various HCPs also may have adopted their own template. So it's always good to have that interaction between your within healthcare partnership to understand what standard template are we using. Within the Kempton Bedway system, we have a specific template. That template is not venturing away from the NICE guidelines, but there are just additional information that we've included in those documents, and those include those information include expiry dates, how you monitor storage, little information to give that extra assurance that the PGDs are being monitored within various organizations. And I found it very useful, those additional add-in to those content. The content of the PGD looks at what requirements of healthcare professionals that need to be administering PGDs. As Tammy rightfully said, there are specific healthcare professional groups that are able to use the PGDs. Those information you can rightfully find via the specialist pharmacist website, and it gives you full information. And I'm saying this because, and also using the specialist pharmacist services as a good resources to which you can get some webinars. There's some pre-recorded webinars that we've had previous PGD training. There are resources in terms of what to do, frequently asked questions. It's a very rich resources out there for you to be able to look back and to understand the processes of the patient group directions across the nation. But joining in Interest Community Health Services, it's a small organization, and we're trying to understand that what we want to make sure is that our patients are getting the right medicines at the right time, and there are no delays. And knowing fully well that most of our organization are probably not medically led, in the sense that we do not have doctors in all services, it then means that we need to be able to focus on how do we meet the needs of the patients for those particular cohort or for those particular service. And those content, you're able to see in the template the healthcare professionals, and then it then looks at giving you guidance about the training requirements. So I do a lot. Yes, they've been approved, they've been reviewed, they've gone through all the process nationally. It's important that they also, from your commissioning point of view, you also get that authorized or reviewed, and giving you that go ahead to say yes, you can deliver. There might be sections on the PGD template for signature from an ICB point of view, and you might even had your own signature from your organizational point of view. So I think different organizations have different needs, but you look at it that it might seem like document heavy, but I think considering the fact that it's a PGD, you haven't got a prescriber working in those documents, there has to be clear guidance. There has to be clear process on how to deliver the PGD from a point of development to the point of execution. And the patient, I always say this, the patient is the heart of this. We need to ensure that the patient, we get to a result where we get a better patient outcome. There's no point to deliver a PGD that puts a patient at risk. And that's one of the key things for me about, PGDs as a whole. I think, in a way, gives us a roundabout information about the governance of PGDs. And I would always go back to the NICE guidelines because it gives you templates. I'll always go back to the SPS, that gives you more information about additional training. The CPP gives you information. ELFH gives you more information also about additional resources that you could use from a training and understanding or raising awareness about PGDs as a whole.